Webinar will discuss some valvular lesions which create heart murmurs. We are going to look at the valvular lesions associated with the left side of the heart. We're going to talk about them more in depth since they're more common. But you still need to understand the valvular lesions associated with the right side of the heart. So there's some things that will still require you to understand concerning valvular lesions associated with the right side, although I'll talk about the left-sided lesions a little bit more in depth. Now, all of these valvular lesions are caused by various things. And on the PowerPoint, you see I've listed some of the more common causes. A lot of people are born with valvular lesions, so it's congenital. Often, following a bout of rheumatic fever, people have experienced some valvular defects. The rheumatic fever is an acute systemic inflammatory disease that usually results after having a strep infection of the throat. And in the process, in the immune reaction, your body starts to attack the heart valves. Specifically, it loves to go for the aortic and mitral valve for some reason, but it's not like it would not affect the other valves. The other common cause of valvular defects is old age. As you get older, just because of wear and tear, some calcification, you may start getting some valvular lesions. Now, before we go over the left-sided defects, I do want to go over some important concepts so you have an understanding of what type of things would create these heart murmurs, or what specific defects could create heart murmurs. So we're going to look at first valves that are stenotic. So somehow the valve becomes, maybe some of the cusps of the valves become fused, where then when they're supposed to be fully open, they're not completely open, and the blood can't go through that valve. So up in the top left-hand corner, you see a normal valve in its open position, so this is going to let the blood go through. Over here, the valve opening is much smaller, so it's going to be harder to create or allow blood to go through that opening. And what's going to happen is, any time in the cardiac cycle where that valve is supposed to be open and fully open, you're going to create an abnormal sound or a murmur, because it's going to create turbulence, which creates vibrations, which then we can hear. So ask yourself, think about the cardiac cycle. You need to ask what valves are supposed to be fully open, say during systole. What valves should be fully open during diastole? And if they're stenotic, it's going to create a murmur. So ask yourself, which valves should be open during diastole? So let's ask you that one first. Think about it. So diastole, we're supposed to be filling up the ventricles, so the AV valves should be open. So here are your AV valves, mitral and tricuspid. So if I have mitral stenosis or tricuspid stenosis, they're going to create a heart murmur during diastole, so they're going to refer to them as diastolic murmurs. Then you need to ask yourself, well, what valves should be open and fully open during systole? You're going to say, well, during ejection, blood is leaving the ventricles, going out into either the aorta or the pulmonic trunk, so your semilunar valves should be open. So if you have aortic stenosis or pulmonic stenosis, that creates what we call systolic murmurs. So let's ask you another question, just so you have an idea about the cardiac cycle again. Mitral stenosis and tricuspid stenosis, since they are diastolic murmurs, when would you hear them relative to S1 and S2? So S1 is created when the AV valves shut. S2 is when the semilunar valves shut. So when you have diastole, diastole occurs following S2. So you'll hear these valvular defects following S2 to the next S1. These two over here, you're going to hear them between S1 and S2, since S1 occurs at the beginning of systole. The other type of valvular defect we're going to look at are we call incompetent valves or insufficient valves, where the valves are not doing their proper job in closing when they should to prevent blood going across when it shouldn't be. So what happens is if a valve is not completely closed when it should be, it's insufficient or incompetent, it's going to allow backwards flow of blood to the valve. And so what they call that is regurgitation. So often some of these valvular defects, you may hear them called something like, say, aortic regurgitation, or they may call it aortic insufficiency. So they use the words interchangeably. So if you ask yourself which valves should be closed during certain phases of the cardiac cycle, but they're not, those valvular defects are going to create murmurs. So you ask yourself, which valves should be closed during diastole? So during diastole, again, we're filling up the ventricles. The semilunar valves should be shut. So your semilunar valves are the aortic and pulmonic valves. So if you have aortic regurgitation or pulmonic regurgitation, they create what we call diastolic murmurs. So you're going to hear these following S2 up into the next S1. When you ask yourself what valves should be closed during systole, the AV valves should be closed. So if you have either mitral regurgitation or tricuspid regurgitation, they create systolic murmurs. So you're going to hear these between S1 and S2. So let's start with our first valvular defect. This is the most frequent pathologic systolic murmur. This could be the worst of all of them, could be the loudest of all of them. Well, in this one, the aortic semilunar valve is narrowed, so it's stenotic. So when is that valve supposed to be fully open to allow blood to go through it? Well, during ejection, which is part of systole. So this creates, if you see here, a systolic murmur. And if you notice by this phonocardiogram, the up and down, the amplitude of this indicates how loud it is. The width tells you how long it lasts. So this is sometimes they'll call it a holosystolic murmur, but generally you're going to hear it for most of systole, even though technically if you notice right here, during isovolumic contraction, no blood's going through, but isovolumic contraction doesn't take all that long. But this creates what we call a systolic murmur because this blood needs to go out through the valve, out into the aorta. So what's going to happen to try to get as much blood as it should through the narrowed opening, the left ventricle needs to create higher pressures to force that blood out. So you're going to see high ventricular pressures. What can happen is cardiac output can decrease. Why would cardiac output decrease? What is the equation for cardiac output? Cardiac output is equal to heart rate times stroke volume. So if you have a hard time getting all that blood out, stroke volume can decrease, and therefore cardiac output can decrease. Now early on, a person may have an okay cardiac output, because how could I compensate for a low stroke volume? I could do it by increasing heart rate. Also, in milder cases, people may be able to adjust to the defect by adjusting the volume of their blood by stimulating something called erythropoietin, which stimulates red blood cell production. Now, depending on how narrowed that valve is, the sound, if you look at the sound characteristics, the sound can be extremely loud, and they describe it as either being loud to harsh. That's the sound characteristics. They say loud to harsh. It's a high frequency murmur. So what part of the stethoscope we're going to use? I'll let you answer that for yourself. You can say it out loud now. So you'll use the, alright, so hopefully you got it right. The auscultatory site. Follow the direction of blood flow. Blood's going to leave the left ventricle, go out to the aorta and up here to the right. So what's the auscultatory site? The auscultatory site will be the second intercostal space, right sternal border. What also is associated with aortic stenosis is a thrill, and a thrill is a palpable vibration. You can put your hand on the patient's chest wall and you will feel it. Okay, so this is something you can actually feel. In response to the increased work that the left ventricle would have to do to try to create that higher pressure would be left ventricular hypertrophy. So you will get left ventricular hypertrophy with aortic stenosis. What type of hypertrophy would you get? Would you get eccentric hypertrophy or concentric? Remember, there's a difference between the two. One is a response to increased afterload, which is this is the case that we see here. Another one is a response to increased preload. So this one has to create a lot higher pressures, so you're going to get concentric hypertrophy with aortic stenosis. So just for the heck of it, let's listen to aortic stenosis. Alright, so that's aortic stenosis. Let's look at aortic insufficiency, which also could be aortic regurgitation. I often use aortic regurgitation. With this valvular defect, the aortic semilunar valve doesn't close when it should, and it should be closed during what phase of the cardiac cycle? Well, it should be closed during diastole. But because it's not closed, blood is going to go back across that valve, go back into the left ventricle. So what's going to happen? The left ventricle has to accommodate additional blood throughout in the cardiac cycle because it's got that backwards flow plus the new blood that's going to be going in, so it's got to move a little bit more blood. So its response is hypertrophy of the left ventricle, and it's going to be eccentric hypertrophy. In this case, remember the chamber size itself will get bigger so it can accommodate larger volumes of blood. It will create a diastolic murmur, which you see right here. Creates a diastolic murmur. Cardiac output can also be decreased with aortic insufficiency because if we call effective stroke volume is decreased because what came out, a lot of it comes back, so never makes its way out into the circulation. So cardiac output can be decreased with this condition. You'll notice that you can also be associated with increased ventricular pressure. Over time, because of increased amounts of blood in that ventricle, pressures may increase. So be careful of saying, well, if I give you some data and say left ventricular pressure is 180 millimeters of mercury, which is higher than normal because it's usually about 120 millimeters of mercury, don't automatically think it's aortic stenosis because over time you can get increased ventricular pressure with aortic insufficiency. One way, or actually two ways, you can distinguish between aortic stenosis and aortic insufficiency is the fact that aortic insufficiency is a diastolic murmur. Aortic stenosis is a systolic murmur. The second way you can distinguish it is by looking at the auscultatory site. Here, remember, keep in mind the idea of follow the direction of blood flow. Blood is moving back into the left ventricle, so it's going towards the apex. So the auscultatory site would be the mitral site, which is 4th or 5th intercostal space, left of sternum, mid-clavicular line. So that's the auscultatory site. It's heard during diastole. Now the sound characteristics. They describe it as being a blowing type blowing type sound. It's high frequency. So it's high frequency like aortic stenosis. Aortic stenosis is loud to harsh. This one's characterized as being a more blowing type sound. So let's kind of hear what this sounds like. Now here's another important thing to write down concerning aortic regurgitation. When this blood goes back into the left ventricle, you're going to have all this additional blood in that ventricle, and what's going to happen to that left ventricle? The left ventricle is going to stretch out. What happens when you stretch a rubber band, it's going to be really more forcefully contract. Because think of the idea of Frank Starling. So you're going to get this real forceful contraction, blood leaves, but all of a sudden it gurgles back into the left ventricle. And when that happens, what's going to happen is if you're feeling a patient's pulse, as that blood goes back into the left ventricle, the pulse becomes extremely weak. But when you have that next round of forceful contraction, you're going to feel a real strong beat. But then it gets weak. And so the term that they use is a hammer pulse, like hammer and nail, hammer pulse or hammering pulse, or a bounding pulse is the term that they use. So what happens is you're going to get, and what we're going to be bringing up at a later lecture too, is you're going to get a high systolic pressure and a very low diastolic pressure because that blood goes right back into the ventricle. And what happens is they can get a very large pulse pressure with people with aortic regurgitation. Now what's going to be common for the aortic valvular defects is you see hypertrophy with both, and it's specifically going to be in the left ventricle. So that's something important I want you to understand. If I ask you, where is the location of the volume pressure overload? I'm asking you what chamber of the heart has had to deal with more volume or more pressure, so it had to hypertrophy in response. With aortic valvular lesions, that location will be the left ventricle, so you'll always get left ventricular hypertrophy. So what type of clinical data could I give you that would suggest you've got hypertrophy of the left ventricle? So this is where it's important to remember the ECG stuff. So I will give you ECG data. The QRS will be prolonged. You will get a high voltage ECG. You will have, you can have imaging studies too, but let's say, okay, so you have high voltage ECG, prolonged QRS, but how would you know it was left side? You would get a left axis deviation. So that would be suggestive of left ventricular hypertrophy. Another indication of a volume pressure overload in the left ventricle would be high ventricular pressures. Left ventricular pressures, that could give you indication of it. Now over time, what can happen is you can get myocardial ischemia because you're going to need more blood flow to that heart. Angiogenesis is not as quick as hypertrophy, and you may not be able to keep up the blood flow to the heart. It could lead to heart failure. Any of these valvular lesions could lead to heart failure. What's also interesting is what you see here. You can get atrial hypertrophy and pulmonary edema with aortic stenosis and regurgitation. So this is the idea, is over time, as left ventricular pressures increase. To compensate for the high left ventricular pressures, atrial pressures will have to get high in order to properly fill the left ventricle. Well, if the pressures in the left atria get high, you can get hypertrophy of the left atria. If pressures in the atria get high too, pressures in the lungs will need to get high in order to get blood to the left side of the heart. And what can happen as pressures get high in the left atria, that could lead to pulmonary edema, where you have fluid leaking out of the blood vessels into the interstitial spaces and eventually into the alveoli, which would impair gas exchange. Now, mitral stenosis is a valvular defect where the mitral valve is narrowed, so it's not open fully when it's supposed to be. So the mitral valve should be open during diastole. So this creates a diastolic murmur. Over time, to compensate or trying to get that blood through a narrowed opening, you're going to get atrial hypertrophy, specifically the left side. Get left atrial hypertrophy. Ask yourself, will it be concentric or eccentric? So to get blood through a narrowed opening, pressures here are going to have to get high to do that. So you're going to get concentric hypertrophy of the left atria. Just like I explained previously, if pressures here get high, you can lead also to pulmonary edema. Now what you'll notice over here is it says cardiac output can be decreased. Why would cardiac output be decreased? Because yet again, this could be a stroke volume issue. If I can't get all the blood through this opening here, eventually it's not going to make it out of the heart and your cardiac output can be decreased. This valvular defect is also associated with a thrill, which is a palpable vibration. So both aortic stenosis and mitral stenosis are associated with thrill. Now this one, the idea how to kind of remember why it creates a thrill is a little bit of information you need to write down about mitral stenosis. This is a low frequency murmur. And I always think when you have bass, if you listen, someone has a lot of bass on their stereo, don't you feel it? Doesn't you kind of just, like just the vibrations? So this is so low frequency, it creates a thrill, which then you feel. Since it's low frequency, what part of the stethoscope are you going to use to listen to it? Will it be the diaphragm or the bell? You need to ask yourself that. So what is it? It's going to be I'll let you answer out loud. Okay, hopefully you got it right. The auscultatory site for mitral stenosis. Follow the direction of blood flow. It's going down towards the apex. So again, the mitral site. It's a diastolic murmur. You notice it kind of gets a little bit louder, especially over here during atrial systole, because that's when the atria are really contracting and trying to force blood through that narrowed opening. So it gets a little bit louder towards the tail end of diastole. The murmur, we said, is a low frequency murmur. It is described as being a weak rumble. That's why they describe it, a low frequency, weak rumble. The pressures here in the left atria never get as high like as you see with aortic stenosis down here. So it doesn't get really loud. So they describe it more as a weak rumble. So let's listen to it. Now, I don't know if you noticed by listening to that valvular defect, could you tell that that heart rate of that patient was a little bit high? Because why do you think their heart rate was high? They're trying to compensate for low stroke volume to try to maintain cardiac output. So that's a common theme that you may see. To try to maintain cardiac output, heart rate may be high if their stroke volume is low enough. Now the last valvular defect is mitral regurgitation. So with this, the mitral valve isn't closing during systole. It's supposed to be closed during systole because when the left ventricle contracts, you want the blood to go out through the aorta, not back up to where it came from. So with this is a systolic murmur. Over time, the left atrial will hypertrophy to compensate for all this extra blood that it's going to have. So ask yourself, what type of hypertrophy would you see? Concentric or eccentric hypertrophy? Again, over time, this can also lead to pulmonary edema because as you accommodate more and more blood, pressures may start to increase there and eventually also again lead to pulmonary edema. You also can have a low cardiac output because yet again, it's a stroke volume issue. The blood's not coming out, it's going up here, stroke volume may be low. We need to ask ourselves, where's the auscultatory site? Where are you going to hear it the loudest? Now this one's tricky because your heart is kind of turned in your chest wall. So this is kind of more a little bit, over here is moved a little bit to the back. So you think, well, it should be going up, follow the direction of blood flow. Dr. Kayes keeps telling me, follow the direction of blood flow. So you're like, oh, it's got to be up here. But because of the way the heart's in your chest wall, the sounds get deflected back down here in the apex. So yet again, the apex is the auscultatory site. So for this one, it's the apex. It's just the phase of the cardiac cycle. It's systolic, so it's a systolic murmur. The characteristics of the sound, how do they describe it? They describe this as a blowing type sound. It is high frequency. So ask yourself, what part of the stethoscope are you going to listen to it? Hopefully you got it right. So with mitral regurgitation, we're going to get a systolic murmur that is blowing, high frequency, best heard at the apex. So let's listen to mitral regurgitation. So what do mitral regurgitation and mitral stenosis have in common? Okay, so the location of the volume pressure overload is in the left atria. They're associated with atrial hypertrophy. You can also have pulmonary edema. So how would you know that you had a volume pressure overload in left atria? Maybe if I give you left atrial pressures that are a little high. They're not supposed to be that high. It's supposed to be max about 7 to 8 millimeters of mercury. So you can get high left atrial pressures with either of those valvular defects. If you have some changes in your P waves, little larger P waves, maybe notched P waves, maybe P waves of longer duration. You can also have atrial fibrillation, because with atrial hypertrophy, that could lead to reentry or circus movements, and you can end up getting atrial fibrillation. So that's what the mitral stenosis and regurgitation may have. Now, one thing I want to ask you is, we've given you the left-sided murmurs, and I've asked you what's the location, or I've told you the location of the volume pressure overload for the valvular defects on the left side of the heart. But you can still be able to tell me what would be the volume pressure overload with valvular defects on the right side of the heart. So if I have a pulmonic, say pulmonic regurgitation or pulmonic stenosis, where would be the location of the volume pressure overload? So either it's going to have to deal with more pressure or more volume, and if I've got a defective pulmonic valve, that blood's going to go back into the right ventricle. So you're going to have issues with the right ventricle. So any type of information I give you would be suggestive of right ventricular hypertrophy, right axis deviation, prolonged QRS, things like that. So what would be the volume pressure overload for the right atria? Or sorry, for the right atria, that is the volume pressure overload. What valvular defects would result in a volume pressure overload in the right atria? That would be tricuspid stenosis or tricuspid regurgitation. So you're still responsible for knowing those for your exam. I'm not going to describe how the sound characteristics for the right-sided murmur, so you're not responsible for any of that. Now the last topic that I want to discuss is if a patient has a valvular defect, is exercise an issue? Well, any of the valvular defects cause issues with cardiac output. You can have stroke volume issues. If it's a milder case, it may not, the person can still exercise, but they may not be able to get up to the cardiac output that a person with a normal valve could get, and it comes to an issue we call cardiac reserve. Cardiac reserve is the difference between a person's maximum cardiac output and cardiac output at rest. So it's the difference between a person's maximum cardiac output and their cardiac output at rest. So if my resting cardiac output is like 4.8 liters per minute, and I can get up to 30 liters per minute, that's not a bad cardiac reserve. But maybe if I've got a valvular defect, I may only be able to get up to 20 or 25 liters per minute. So you may have an issue with cardiac reserve. With more severe cases of valvular defects, they may have little to no cardiac reserve, which limits their ability to carry out even sometimes simple tasks. So someone with a more severe valvular defect should not exercise because it can put them right into heart failure. So you have to be very careful with patients with valvular defects to make sure if they're mild or severe, it's going to limit their ability to exercise. So this is going to be the end of the webinar for now. Now we're going to discuss what we're going to be doing in lab.